for design or pitting two or more theories against each other, where they would have disparate expectations and seeing which one prevails. And then there's theory building, which is more of a kind of a basic science application. And when I say basic science here, I'm not just talking about bench science or wet labs, academic, psychological researchers who are conducting small RCTs with Psychology 101 students, I would consider to be basic science if they're doing theory testing and theory building. But my focus today is on application and testing. So and as a theme for today, there's a whole lot of bouncing around that I have to do to get all of the moving parts together. So before we move on, I want to introduce, if you don't know already, this kind of conceptual decomposition of generic effect types. I think this probably came out of the psychotherapy research field. So specific effects are the effects of, say, an intervention that are postulated by a theory. So if you're going to attribute the effect of an intervention to a theory, then, or the particular effects to a theory, those are referred to as specific effects. And when you're talking about this, what I mean is you've got a theory on, let's say, some kind of behavioral health theory, and you're interested in a specific outcome. And so the theory is going to inform what might instill change in that outcome. And so we're talking about theoretical mechanisms here acting upon a specific outcome. There's also in behavioral interventions going to be what are known as non-specific effects. And these might be things like you might have a theory that informs your intervention, but there's all these other contextual factors like maybe the intervention is delivered in a group setting and there's a kind of a positive warm vibe there that's supportive, and you know, people are making it a pleasant experience. Those kinds of things are not necessarily theoretically described, but may have an impact. So the non-specific versus specific really has to do with whether the theory delineates a certain mechanism versus does not. Common effects are really a subset of non-specific effects. And those are, so if you have an intervention and a control group, in some cases you might expect that some of the non-specific effects are common across the intervention and control group. So in a drug trial, if you have a placebo control, there's going to be expectancy effects for both the compound, the experimental compound, and placebo. So those would be common effects. And then total effects is a combination of specific and non-specific. In most designs, you can't directly estimate specific and non-specific effects unless you're going to impose some untestable assumptions. And really, I do want to point out that if you take a unified theory perspective, non-specific effects are shortcomings of your theory. In other words, your theory is too narrow to incorporate all of the important facets that might affect the outcome of interest. And just as an aside, common effects are usually called common factors, which I think is a mistake, and I think has led to some confusion. What I call common effects are a subset of non-specific effects, so clearly they are effects. And there's a difference between factors and effects, because common factors don't necessarily have common effects. So next I want to make a distinction between tested theory versus testing a theory-informed intervention. If you're testing a theory, your design should really be able to definitively estimate the effects of the kind of the mechanisms of the theory. And that's really specific effects. So you really are after specific effects, which means you need to design an RCT that's going to directly estimate specific effects. So experimenting, comparing an experimental drug versus a placebo is an example of this. And both the drug and the placebo have expectancy effects, but only the experimental drug has a theoretical effect due to its composition. Then that's an example of getting at a specific effect. In my mind, theory testing is in the realm of basic science. Testing a theory-informed intervention is different. It's applied science. I think that an RCT in this realm should be designed to estimate total effects, not specific effects. And as far as I can tell, efficacy, effectiveness, and implementation RCTs focus on total effects. Now there's some blurring that happens in the scientific community. That there's a lot of attempts out there to estimate specific effects in the context of efficacy, effectiveness, and implementation science. I think it's wrong. I think it's because people aren't being deliberate and clear enough in their thinking about what the goals of the research are. So an example here is that, maybe there was a drug trial that happened previously, a drug is approved, it goes into, it's commonly used and prescribed after years. Providers find that it works really well, has no side effects, and so the provider gives the prescription to the patient with confidence. And then all of a sudden you have the effect of the drug itself, plus the effect of contextual factors that the doctor is providing with their relationship with the patient that actually improves the effectiveness of the treatment regimen. And there's a study here that I list at the bottom where this was demonstrated. So this is applied science. If you want to know what works best, you don't care about specific effects only. You care about the whole context of care delivery, so to speak. And so I think public health investigators need to more deliberately consider this distinction. There may be some public health investigators who, at least some of the time, are involved in theory testing, but I suspect that most people are involved more in applied testing of interventions than actually testing theories. So if you're in the realm of intervention testing versus theory testing in public health, there's this kind of a distinction that's not really a distinction, it's a continuum. We'll get to that, but it's efficacy versus effectiveness. And so in a nutshell, does the intervention do more harm than good when delivered under optimal circumstances? That's efficacy. Or does it do more harm than, or good than harm, when delivered under real world circumstances? That's effectiveness. But if you're talking about more good than harm, compared to what? If, in my opinion, you want to inform policy, the comparator needs to be clinically relevant, or at least those who are doing research that's not clinical, it has to be relevant from a healthcare delivery decision-making standpoint. And this is, again, evidence-based medicine requires medicine-based evidence. An efficacy trial is going to try to maximize internal validity. Effectiveness trial is going to maximize external validity. And they can differ in a lot of ways. How much control you have over the fidelity of the intervention, the kinds of participants who are enrolled into the study, whether or not the outcomes are kind of more near term or longer term, whether costs are, like in an efficacy trial, you spend a lot of money on the intervention. In the effectiveness trial, you don't, but you're more interested in understanding the costs, the cost benefits. So there are differences, but there's not necessarily a difference in the kind of control group that you would choose. typically. So as I said, efficacy and effectiveness exist along a continuum. And this is another kind of area of distinction that a lot of investigators don't consider as carefully as they might. I think that we've got limited human capital, limited time, limited money. We can't have a bunch of effectiveness trials before we get to, excuse me, we can't be conducting a lot of efficacy trials unless it's absolutely necessary. We need to move towards effectiveness as soon as we can. And that means that when you're designing your randomized controlled trial, I think it's incumbent upon us to think about how far we can reasonably push the design toward effectiveness. We don't want to be efficacy all the way unless we have to be, because if you unnecessarily have too much of an efficacy focus, it just means that you're going to have to conduct more research before you get down the road toward effectiveness. It means that you need to recruit more participants into studies, means that you're putting more participants at risk because of extra research that's not necessarily required, and it's unethical. And we don't have time. We need to move forward as fast as we can. So I don't know if people know about the stage model, but it's different from, you know, phase 0 through phase 5 kind of drug trial, but it's similar in a lot of ways. And the reason why I point this out is they make a distinction between and I screwed up in my parenthetical there next to stage 2. It should say research setting, research-based kind of settings you may skip. Stage 2 is an efficacy trial that's conducted in a research setting. So you've got research interventionists, research staff, etc. Whereas a stage 3 efficacy trial is done in a community setting where you've got community interventionists, etc. A lot of people involved in community-based research will skip stage 2 because it's really not of interest. You usually don't need to demonstrate that you can conduct an intervention in a research setting with a lot of community-based research. And it's interesting because in stage 1, that's where you would create or adopt or refine your intervention and pilot test it. So in stage 1, if your next goal is to have a research setting-based efficacy trial, then your stage 1 activities would be focused on optimizing your design for that setting. But if you instead had a stage 1 activity where the next step was to go to a community setting for your trial, then your stage 1 activities would be optimized for that. So it's possible that you would go from stage 1 to stage 2. After stage 2 is completed, you would go back to stage 1 to refine your intervention for the community setting, and then go to stage 3. So it's not a completely linear process. And the more you can, if you can skip stage 2, you're going to skip stage 2 and another stage 1. So it's all about thinking about how you can move forward as quickly as possible. Okay, so that's a lot of background. And I want to talk about some specific types of control groups. So these are the 3 I'm going to focus on most. There's some others that I'll mention. But the attention placebo control is like sham therapy. So this is pretty much coming from psychotherapy research. And the idea is that you're going to have this control group that's intervention that looks like real psychotherapy, that the patient thinks is real psychotherapy, but is completely inert when it comes to specific effects of that shams therapy on the outcome of interest. So say you've got psychotherapy for clinical depression, you've got some theoretically informed psychotherapy approach that is going to be tested, and the investigator wants to come up with a sham psychotherapy that looks like the participant, that it's actually valid psychotherapy to help reduce depressive symptoms, but actually has no active ingredients in it. It's the holy grail of psychotherapy research. I'm not sure it's attainable. It sounds like almost impossible when you're talking about behavioral interventions. If you're doing a procedural kind of thing like acupuncture, you could have sham acupuncture and the patient may not know it. But for something like kind of a talk intervention, I think it's pretty tough. But I do want to bring this up because I think it's important to understand where time and attention control came from. So I think a lot of people felt that attention placebo control and behavioral research really wasn't tenable. So they came up with a time and attention control. And I think the thinking was, well, I can't really have this kind of credible sham intervention, but at least I can control for the amount of time and attention that participants have to engage the intervention. And so you end up having interventions with really different content. So you've got like, your main interest is in sexual risk behavior reduction. So maybe you come up with a control group that's diet and exercise. So there's just as much kind of quantity of content and contact and kind of attention that has to be paid across these two sets of interventions, but they're really after different content. And then finally, usual care, sometimes referred to as unrestricted standard of care. Patients just, so you assign patients to get the experimental intervention or to basically get what they get in the wild. There's natural variation in usual care. It's not standardized. And it's important to note that it provides a solid kind of basis for understanding excess adverse events within the experimental condition, because usual care is kind of gives you a base rate for those kinds of things. Here are some other control group designs, which standard of care is basically protocolized standard of care. So it's like enforcing a certain standard instead of usual care, which could be variable. Waitlist control is sometimes used in communities where it's unacceptable to the community to just have a usual care kind of condition. So you're offering something to everyone, and that sometimes helps. And then there's dismantling controls where you have multiple experimental conditions and with different numbers and combinations of active ingredients in each of those. But I won't talk about that. So again, going back to specific effects, non-specific effects, common effects, and total effects, I want to kind of do a conceptual decomposition of these three control group types, just to see what you might expect to get when you estimate your group difference at the end of the day. So for attention placebo control, it's kind of like a sham risk reduction intervention. Time and attention, it's going to be diet and exercise versus, say, a sex risk reduction intervention. And usual care is whatever participants access on their own outside of the study. So this is an attempt to kind of clarify, and you can tell me if it clarifies or confuses. But we've got a row for the intervention group, a row for the attention placebo control, and then we've got specific kinds of effects listed here. And so we've got this S int, that's the specific effect of the intervention of the sex risk reduction. So this is the theoretically indicated kind of effects that you would expect based upon mechanisms of action. The APC is a sham. So if you believe that APC is truly inert, then there won't be any specific effects of APC on sexual risk behavior. Now, if you believe that APC looks like a sex risk reduction intervention to the participants, and pretty much is delivered in a similar way, similar context as the actual experimental intervention, then you might be able to make an argument based upon assumptions that all of the non-specific effects of both interventions are common. So you've got time and attention, but you've got time and attention focused on content that is identical across the two interventions. It's about sex risk reduction. So if there's any non-specific effects across these two conditions, you might make an argument that they're common, that there are no non-common, non-specific effects. Untestable assumption. So if you believe all of that, then the total effect of the intervention group is going to be the specific effects plus the common effects, and the total effect of the APC is only going to be the common effects. Take the difference and you get what's in the yellow highlight there, the specific effects of the intervention. Sounds good. It's what you would want if you were testing theory, because what you really want is an estimate of the specific effects of your theory. If there's no specific effects of your theory that are detectable, then there's probably something wrong with your theory. But this is the ideal outcome, and I just think that it's kind of implausible. There's a lot of untested assumptions here, and many have argued that it's kind of unattainable, just conceptually in behavioral research. But I think it's a good introduction to all of this. So moving to the time and attention control, so here we have a sex risk behavior intervention and a lifestyle intervention that's supposed to be matched on amount of time and attention. On the top panel, we've got the ideal outcome, which is just like it was for APC. But there's a lot of untested assumptions, and there's a lot of reasons to suspect that that won't bear out. So looking at the next panel, if your lifestyle, if you've got this lifestyle intervention, then you could probably make a pretty good argument that there's no specific effects of your lifestyle intervention on sexual risk behavior. So I think, I'm going to buy that one. But then you move over to the non-specific effects. And I think it's really difficult to make the case that there would be common effects in this case, because you can match on time and attention, but time and attention within the context of a sex risk reduction intervention is plausibly related to sex risk behavior if the intervention is effective. Time and attention in the context of a lifestyle intervention, I can't figure out how it's going to be positively related to sexual risk reduction. It just doesn't make sense. Now, it could be that time and attention in the lifestyle intervention is negatively related to the outcome because you're distracting participants away from potentially thinking about their sex risk and making them think instead about diet and exercise. So it's possible that you end up having competing demands, and that not only, it's possible that time and attention is a positive influence within sex risk or zero influence in lifestyle, but it's also possible that it's a negative influence in lifestyle. And there's plenty of studies that have shown this. Well, there's several. Some studies have had active intervention, time and attention control, and then unusual care. And there's several examples where the time and attention control does worse than usual care. And so there's a real possibility that this distraction effect is happening. So I think that this bottom panel is much more plausible than the top panel. The yellow highlight shows the nature of the effect estimate that you would get when you compare groups on the outcome at the end of the day. And if there is a negative effect of specific effects in the time and attention control, then you're going to overestimate your treatment effect. But more importantly, in my opinion, you're comparing an experimental intervention versus a lifestyle intervention. I mean, sex risk versus diet and exercise. Who cares about that distinction? Someone might, but most people who might be making a policy decision about whether to implement your sex risk reduction intervention, they're not going to be interested in that comparison. I would think they would want to know, how does the experimental intervention compare to what is kind of commonly available, not pitting two disparate active interventions against each other. But let's just say, for the sake of argument, that there were no specific effects of the time and attention control intervention. Then what you would get, it would be a better result for sure. And what you would get is basically the total effect in the intervention group. That's a useful quantity to know, but you don't know if that's what you're going to get without making some assumptions. And I also want to point out that when the investigator decided to use the time and attention control, what they were really trying to get at was the specific effects of their intervention. What they're getting is the total effects. So they're not getting what they asked for. So they went to a lot of trouble, spent more money on building a lifestyle intervention, and they're not getting what they set out to get.
Would it be closer on this continuum to effectiveness?
Yes.
Still be worthwhile?
It might still be worthwhile, but again, it rests on untestable assumptions, because I think this is a possible outcome. I think the second panel here is at least equally plausible, and maybe more plausible, depending upon the nature of the interventions that you're talking about, just because of the distraction factor. So so this is an example, I'll just jump ahead, where time and attention control is clearly contraindicated. So I've been involved in some implementation science projects where you're basically trying to, there's a lot of evidence-based medicine that there's no time to fit into a regular kind of doctor visit, primary care visit. And so you're always looking for ways to allow doctors to kind of get to some of the, like smoking cessation or breast cancer screening discussions with their patients. And so one idea is patients in the waiting room, and they fill out some questions on a tablet, and then it kind of calculates a risk score, and it makes some kind of recommendations. You get a printout before the visit, patient has a printout, doctor has a printout, and the doctor can use this to talk with the patient in a more efficient manner about their risk reduction or any kind of tests they might need, or going to talk to the genetic counselor. Some people have proposed, well, in this context, we need a time and attention control. And I said, well, no, you absolutely do not want a time and attention control, because if you randomize patients to have, say, breast cancer risk reduction on the tablet with a queuing sheet, go talk with your doctor, you're trying to promote breast cancer related discussion with the doctor. If the other patients who are assigned to the control get exercise, then what are they going to do? They're going to go in the visit, they're going to talk with their doctor about exercise. That's going to distract them from talking about breast cancer screening. So you're stacking the deck against, you know, your outcome of interest. And I mean, it's really clear here that you're stacking the deck and you're going to overestimate the effect of your experimental intervention. But in some other cases, it might not be as clear. But that's one example. So going back to the decomposition, now we've talked about attention placebo control and time and attention control. So this is usual care. So usual care, hopefully usual care is going to have some, you know, if usual care is more than do nothing, there's going to be some specific effects of usual care, some specific effects of your experimental intervention. There's going to be some non-specific effects of both as well. And you kind of like add them all up and subtract them from each other, and what you get is the total effect of the experimental intervention versus usual care. Now, it looks messy, but it is a relevant estimate of intervention effect because UC is relevant. Now, previously we were talking about time and attention control, diet and exercise. Is that relevant for making a policy decision about the experimental intervention? Probably not for most people. In this case, usual care is directly relevant. Now, usual care varies from location to location and even within a study. But if the usual care in the study approximates reasonably what the policymaker is looking at in terms of their usual care, it's going to be informative. And none of this requires assumptions. There's about whether or not there are specific effects, whether or not there are non-specific effects, whether or not the non-specific effects are common effects. No assumptions. It's just, it is what it is. So, ethical considerations. We want to minimize human subjects' activity required to inform our policy decisions related to health care delivery. I think investigators need to carefully consider whether their study is theory testing or intervention testing. And part of that is trying to ask yourself which approach is more likely to maximize benefits and minimize harms to society. If you need to do theory testing, okay, but be deliberate about it. And if you really are going to invoke some kind of theory testing paradigm in a behavioral health intervention setting, you really have to ask yourself if you can design a control group that plausibly allows for the estimation of specific effects. If you're in the intervention testing realm, then you need to consider where you are on the efficacy effectiveness continuum. And I think you should try to move yourself as far toward effectiveness as you can, as is appropriate at that time, and choose a control group that will best inform policy decisions. I'm not going to read them all, but you know, as I said before, usual care also provides a basis for safety monitoring, because if you have, say, I mean, you could have some kind of comparison group that wouldn't really give you an understanding of what the adverse event base rate is. So your DSMB, when they're looking at your adverse event rate in a study without usual care, they're not going to have a good idea of whether or not your adverse event rate represents excess risk. It may not be a big deal for a lot of behavioral interventions that are kind of low risk studies, but it is something to consider. Some people have argued that because usual care is not always up to the standard of care, that it's unethical. I don't buy that argument. I think it's probably the case that in a true effectiveness trial, it's always usual care that's the comparator. And so it's not unethical there. Why would it be unethical if you're closer to efficacy? The bottom line is you're trying to inform policy decisions, and if your ethical viewpoint forces you to only conduct kind of irrelevant research, then that's unethical because you're putting subjects at risk without getting to the end game. And you know, I think there's a lot of kvetching out there about wanting to know specific effects. I think advocates of time and attention control think they might be getting at specific effects, think that specific effects are the only game in town. I don't think that's right. I think total effects are important to know. So, proposal strategies. You write in your proposal and you say you're going to use usual care, and you get some reviewer who says, no, you can't do that. Happens a lot. Many reviewers will insist that you have time and attention control. This leads some investigators to always propose time and attention control. And those kind of reviewers, they don't seem to get much resistance from other reviewers in discussion. So if you're going to propose usual care, you need to make a strong case for it. You don't just say we're going to have usual care. You need to explain why you're going to have usual care. You're essentially giving the committee members who are sympathetic with you ammunition that they can use in the discussion of your proposal. If you can plausibly claim that yours is an effectiveness trial, then I don't think anyone has a problem with usual care. But I got to point out that it's strange to me that if usual care is okay for effectiveness, why isn't it okay for efficacy? Doesn't make any sense. If you can argue that your primary goal is to inform health policy, and that understanding the total effect is what you really need to understand, that might help. But that's a tough sell. If you can argue that time and attention control would stack the deck, and perhaps overestimate the intervention effect, I think that would help. Or if you can argue that TAC is or that UC is needed for safety monitoring, I think that helps as well. Not guaranteed. This is churchy, as I say. It seems to be tribal, and it's hard to, in the context of a proposal where the investigators have very little recourse, it's kind of dangerous territory. But if you want to be absolutely safe, at this point in time, you can propose time and attention matching.
So another argument against TAC is where's equipoise at trying to randomize participants? There's no proposed benefit coming from the TAC control.
Yeah, no, you're absolutely right.
Maybe one more bullet in your...
No, you're absolutely right. It's funny because I was going to talk about equipoise in this, but I had never considered that angle on it. That's very good. Thank you. So with manuscripts, it's kind of a different story because you've got lots more power in that situation. Occasionally, reviewers complain that it should have been time and attention matching, but it's easy enough to write up a response negating that critique, I think. And really, at the end of the day, all you really need to do is convince the editor, because they will shut down the reviewer if they need to. So here's just the summary of what's the difference between theory testing and intervention testing. One thing is that I didn't mention is that theory testing really tries to get at mechanisms of action through specific effects. So it's really trying to design the study to detect mechanisms of action with the group comparison. Whereas in intervention testing, you're going to be relying on mediation analysis. So that's the end of that one. I hope it was clear. I think I took longer on that one than I wanted to. But any other questions?
How do you see most designs fitting into this?
Oh, wow. Haven't even thought about that.
Because I mean, those purport to get at mechanisms of action, but in a very, internally valid kind of way.
Right.
With factorial, fractional factorial.
Yeah, I mean, there's a lot you can do if you're going to have a more elaborate design with more conditions. You can really kind of try to decompose things. But, in my opinion, most of the kind of RCTs that we propose are these like 5-year, 500 to 1,500 people, kind of, at least a year of follow-up, if not longer. And just having kind of more expensive, elaborate kind of designs that are really, you're trying to detect pretty small effect sizes and things like that. It's kind of problematic. So I just punt on that one, and I don't know if it's. I mean, I'm sure there's like micro randomized trials and things like that too. So this is a very simple take on the old school, intervention versus control kind of design. But interesting. I'll think about that.
So it seems like there's a package. Like if you're gonna do this, create your stages, but if you're gonna do a really, you feel like you have to do a tightly controlled trial, it seems like that's when you're gonna most likely to get at the specific effects. And it's sort of like you go together. But if you're gonna say, no, we're not gonna do this, we're gonna go in the real world, and you're gonna get the internal validity and maybe the repeatability that the NIH is going after. If you say you're gonna do a pragmatic trial, then where you're not going after specific effects. It feels like two different things, and maybe your point. My take-home message is maybe you have to be really clear on which one you're doing and why. But if I were to do a tightly controlled trial and then have a usual care arm, it doesn't seem to match up.
Well, okay, so think of 3 distinctions: theory testing, pure efficacy, and pure effectiveness.
Yeah, I'm putting efficacy and theory together. Maybe.
Well, there's a whole kind of theory of mine. There was this 1967 article that basically was before people were talking about efficacy versus effectiveness, but and what the authors, Schwartz and somebody, what the authors were talking about was explanatory versus pragmatic. Careful reading, their explanatory is sometimes theory testing, and it's sometimes efficacy. Their pragmatic is anything on the efficacy effectiveness continuum, but probably more toward effectiveness. So there's been some confusion on the use of the explanatory and pragmatic labels, because they've kind of been, some people just kind of map them directly onto efficacy effectiveness, and that's not quite right. But if you make a distinction between theory testing, pure efficacy, and pure effectiveness, then a pure efficacy trial is just as tightly controlled as a theory testing trial. You're going to have to spend lots of money making sure that your intervention is delivered with high fidelity. You're going to be tracking down your participants like crazy to make sure you don't lose them to attrition. There's going to be lots of monitoring of all the activities, etc. So I don't think that I'm not going to go along with the fact that that a pure efficacy trial is looser or less controlled than a theory testing trial.
I don't think I
it would be the same.
saying that. I was like putting them together in a bucket, because why would you do efficacy without the tight control. You would, right?
Well, you would, if it was pure efficacy, it would be really tight control,
Yeah.
but it's the
Okay.
choice of the control group that distinguishes between theory testing and efficacy, and it not the tightness.
Right.
Of
They just
of the
seem so
controls.
linked to me. Like,
Right, and see, this is what I'm saying.
but I realize they're different.
Investigators need
notes.
to kind of be more deliberate and separate those things out, because there's been a blurring. And the blurring has kind of, what's won the day is you should have a time and attention match control because of this blurring. And people haven't thought it through enough. We need to raise the debate.